Welcome everyone, and thank you for joining us on this FP2020 webinar today. It is my distinct pleasure to begin this webinar by providing an update on the FP2020 Partnership. Today we're very excited to launch our partnership's 5th annual progress report, The Way Ahead. As in past years, the report includes new estimates on the number of additional women and girls using modern contraception in FP2020's 69 focus countries. But the report is a little different this year because of the global context. We're calling it The Way Ahead because that's what we think the FP2020 Partnership is, a model for how to move forward in this era of uncertainty and change for the global sexual and reproductive health and rights community. In this briefing, we'll provide an overview of the report, drill down a little on the way ahead, and highlight the key progress updates from the report. I want to walk you through the agenda quickly and also thank the experts that have joined us today to present their findings and contributions that are critical components of the report. This includes Jason Bremner, Director of Data and Performance Management at FP2020, and Adam Wexler, Associate Director for Global Health and HIV Policy at the Kaiser Family Foundation. Thank you both for joining us today. Our hope is to leave plenty of time at the end of this webinar for questions. To that end, on your screen, you'll see a box through which you can submit questions throughout the course of the presentation. If you're on the phone line and not able to access the webinar, then please email your questions to info@familyplanning2020.org. So, in the 5th year of our partnership, we, and in fact the entire reproductive health sector, find ourselves in an era of global uncertainty. But the mission of FP2020 is as pertinent and compelling as ever. Every woman and girl must be able to exercise her basic human right to control her own reproductive health. Rights-based family planning programs have a greater ripple effect than almost any other development investment, from saving lives and improving health to strengthening economies, transforming societies, and lifting entire countries out of poverty. It is the surest path to the future we want. And over the past 5 years, FP2020 has pioneered a country-led, globally backed development partnership that will help us to travel that path. FP2020 Partners are reaching millions of women and girls with the services they want and need, and collaborating across countries and sectors to build stronger, more diverse, and sustainable family planning programs. As of July 2017, more than 309 million women and girls in the 69 FP2020 focus countries are using a modern method of contraception. This is 38.8 million more than were using contraception in 2012 when the FP2020 Partnership was launched. This increase is approximately 30% above the historical trend. From July 2016 to July 2017, the use of modern contraception in the focus countries prevented 84 million unintended pregnancies, 26 million unsafe abortions, and 125,000 maternal deaths. The annual analysis from the Kaiser Family Foundation indicates that bilateral funding for family planning, however, declined in 2016 for the second year in a row, essentially retreating to 2013 levels. Jason and Adam will delve more deeply into the key findings from the measurement section of the report and this financial analysis later in this webinar. So for one of the high points of the year, the Family Planning Summit in July was a tremendous moment for our partnership and for the entire family planning community. More than 3,000 people participated in London and in 34 satellite events across 24 countries, demonstrating that this community is united, resilient, and ready to meet the future. One of the most valuable aspects of the summit was the opportunity to bring together the front lines of the family planning community, who work tirelessly year in and year out to build strong, sustainable, rights-based family planning programs. These are the policymakers, program managers, service providers, and advocates who are the backbone of this sector, and it was a privilege to witness their dedication. It was also inspiring to hear the voices of young people who are stepping up to take charge of their own futures and to realize how far we've come since 2012. The FP 2020 commitments announced at the summit are more detailed, targeted, actionable, and measurable than ever before. Countries are truly leading the way and setting the pace of progress within their own context, with country commitments shaping the direction of the partnership. Partners are poised to deploy next-generation solutions in supply chain strengthening, financing, data collection, and contraceptive technology. Adolescents and youth are now front and center on the agenda, and new initiatives from governments and donors are tightly targeted to fill gaps, shore up weak spots, and reach women and girls where they are, including in humanitarian settings. In addition to the individual commitments, 11 global goods were announced. These are group initiatives designed to solve persistent challenges across the family planning sector. The global goods promise to channel more resources into capacity building, forge pathways to sustainable domestic financing, resolve commodity spending gaps, strengthen global and domestic supply chains, ensure that adolescents are counted and their needs are met, and address the needs of women and girls in crisis settings. The summit marked the single largest expansion of the FP 2020 Partnership since this initiative was launched. We welcomed 25 new partners to FP 2020, including 3 focus countries, Chad, Haiti, and South Sudan. We also welcomed 3 new donor countries, 6 new civil society organizations, and 13 new private sector partners. That means the FP 2020 Partnership now includes 41 of our 69 focus countries. In addition, on International Youth Day, we announced the first ever FP 2020 commitments made by youth-led organizations. And dozens of our existing partners stepped up to renew their FP 2020 commitments this year, outlining new objectives, reaching more women and girls, and in particular, dedicating larger budget allocations and delivering more resources. Mobilizing domestic resources for family planning is vital to the long-term sustainability of family planning services, and 17 FP 2020 countries made quantified domestic financing commitments at the summit. These pledges total approximately $3.8 billion and mark a growing commitment by countries to fund their own programs. A total of $2.6 billion was pledged by 14 donors at the summit, including commitments by 4 first-time commitment makers, Canada, Belgium, Finland, and Iceland. Increased financial commitments were also announced by Australia, Denmark, the European Commission, Luxembourg, Netherlands, Norway, Sweden, and the United Kingdom, as well as by the Bill and Melinda Gates Foundation and the Children's Investment Fund Foundation. As in 2012, the U.S. did not announce a financial commitment. 5 civil society organizations announced financial commitments at the summit, totaling approximately $64 million, and 7 new partners from the private or corporate sector made financial commitments totaling almost $19 million. So the FP 2020 Partnership is growing, vibrant, and unique, and this year's report is really the story of our partnership. As many of you know, FP2020 is a country-led, globally backed movement to empower women and girls by investing in rights-based family planning. And when we say FP2020, we mean all of us, the governments, the donors, the implementing partners, the advocates, the youth leaders, all of us. We're all FP2020. We're all in this together, all working to realize our shared vision for the future. Because of this focus on country action and country progress, today I'll speak first about our work with countries, then turn to the partnership's role and work within the global health and development architecture to support country progress. But I want to start with our shared vision. We've articulated this in the report, and I think it bears reading so that those on the phone will also be able to hear it. And our vision is this, that we're drawn forward to a future where every woman and girl is able to take charge of her own life, plan her own family, and determine her own destiny. We aim to realize that vision through country-led family planning programs that are grounded in a rights-based approach, informed by broad stakeholder engagement, implemented using evidence-based practices, underpinned by a robust measurement agenda, funded through sustainable financing streams, and accountable to all. Now I'll take a moment to help everyone understand how FP2020 works. One of the things we'd heard repeatedly over the last years, people understand that there's a partnership, they see the effort going forward, but what's actually happening in countries and how are partners coming together to realize this? So again, the FP2020 platform has proven to be effective, flexible, and resilient in the face of all the change that we've seen in the sector. And that's why we're dedicating a portion of the report to explaining how all this works. The report includes a step-by-step overview for how FP2020 countries, donors, and partners work together to implement programs that are grounded in human rights principles, based on evidence and data, and accountable to stakeholders. This slide is an excerpt from the conceptual map that opens section 1 of the report. That section walks through the FP2020 process in countries, along the way provides progress notes related to each topic. This slide shows another excerpt from the conceptual map in section 1 of the report, illustrating the key elements of a family planning program and the central role costed implementation plans continue to play. Costed implementation plans, or CIPs, cover all the major thematic areas of a program: financing, enabling environment, social and behavior change, service delivery, supply chain, and monitoring and evaluation. Respect for and advancement of reproductive rights are the overarching principle that informs the entire program. Accurate data provide a solid foundation. High-impact practices are evidence-based interventions that can be used throughout the program for maximizing effectiveness. And the FP2020 process in countries is designed to foster transparency and accountability at every step. The cornerstone of FP2020's country engagement strategy is the focal point structure. When the focal point system was established in 2013, the country teams included only representatives from the government and donor agencies. This past year, we began the process of expanding each country team to include a civil society focal point as well. Civil society organizations are essential partners in the family planning sector, and including a CSO representative on the focal point teams better reflects how family planning programs and in-country technical partnerships really work. The Asia Focal Point Workshop in May was the first FP2020 workshop to include civil society focal points in each country delegation. Civil society focal points also joined country teams for the workshop in Mali just a few weeks ago, where delegations from 15 Anglophone African countries outlined together how they'll operationalize their country action plans, which we refer to as Actions for Acceleration Plans. These plans are in alignment with country CIPs and are made available on FP2020 web pages. The regional focal point workshops are at the heart of what FP2020 does. They provide the space and technical assistance for countries to refine and assess their rights-based family planning strategies. Each focal point workshop has 3 main goals. to accelerate progress on the country's family planning goals, to broaden the evidence base through South-South collaboration, as well as knowledge exchange between countries and technical experts, and to strengthen the FP2020 collaboration with partners and stakeholders in country, within regions, and across the global partnership. PIPs, focal point workshops, and country action, in combination with our efforts on the global stage, combine to form an overall framework of accountability based on taking action, monitoring its effects, and reviewing to refine future action. The Secretariat has also developed a new tool to help countries operationalize rights-based family planning, called Rights-Sizing Family Planning, a toolkit for designing programs to respect, protect, and fulfill the rights of girls and women, and it offers practical guidance on incorporating rights principles into every aspect of a country's family planning program. Human rights are critical to FP2020's vision and mission. Determining how best to put the rights-based approach into practice is a key area of work for our partnership. For example, in the lead up to the summit, 35 representatives from governments, NGOs, and donors issued a quality of care call to action for family planning in FP2020 countries. It includes a detailed set of recommendations to improve quality of care in the context of rights-based family planning. And this year, we launched a rights-based family planning microsite that serves as a central repository for information and resources about the rights-based approach. In addition, we've also developed a new web resource for youth advocates on adolescence, youth, and family planning. Both of these microsites include the latest data, evidence, and best practices. And on the youth microsite, you'll find a really innovative youth network map with contact details for over 200 youth-led organizations in the 59 FP2020 focus countries. As I've noted before, FP2020 is a country-led and globally backed development partnership. And now I'd like to turn to some of the important ways in which FP2020 connects to and is supported by the global architecture in pursuit of our FP2020 goals. We're aligned with the Every Woman, Every Child global strategy for women's, children's, and adolescents' health, and the commitment to FP2020 is included as a commitment to Every Woman, Every Child. FP2020 also coordinates with other global and regional initiatives in the reproductive health sector, including the Ouagadougou Partnership, the Reproductive Health Supplies Coalition, the Partnership for Maternal, Newborn, and Child Health, and the World Bank's Global Financing Facility and Sahel Women's Empowerment and Demographic Dividend Project. Through these strong integrated relationships, we seek to realize the potential of rights-based family planning programs as having a greater ripple effect than almost any other development investment. Effective family planning programs that are thoughtfully integrated into a country's primary healthcare system has been designed to deliver on the full range of SRMNCAH continuum of care have enormous potential to save lives, improve health, strengthen economies, transform societies, and ultimately lift entire countries out of poverty. The FP2020 Reference Group provides overall strategic direction for the partnership. One of the greatest strengths of the Reference Group is its diversity. The composition of the group has evolved and expanded over the course of the initiative to ensure that a variety of viewpoints and expertise are represented. Last year, a new youth seat was created. This year, the total number of seats was increased from 18 to 23 to strengthen representation from partner countries, including ministers of health from 7 countries, and to include leaders from the faith and feminist communities. The structure of the reference group also facilitates partnerships across the global health architecture, with the World Bank, the World Health Organization, UNFPA, TMNCH, and the largest family planning donors and foundations all represented. The opportunities for effective cross-institutional collaboration and alignment are enhanced. As global advocates for family planning, the reference group works to ensure that family planning remains a high priority on the global agenda. Recent notable reference group moments, including our fall reference group meeting in Abuja, Nigeria, which had been a long-standing vision of Dr. Babatunde Oshotemen, and a high-level political meeting with Vice President of Nigeria, Yemi Osinbajo, that included senior representatives from each of FP 2020's core convening organizations, UNFPA, USAID, DFID, and the Bill and Melinda Gates Foundation. With the passing of Dr. Oshotemen, our fall meeting was co-chaired by Dr. Natalia Cannon, who had recently been appointed Director of UNFPA, and as always, Dr. Chris Elias, Director of Development for the Bill and Melinda Gates Foundation, who has co-chaired the FP 2020 reference group alongside Babatunde since our inception. With that, I'd like to wrap up my top-line update on the state of the partnership, and I'll turn to my colleague Jason Bremner, FP 2020's Director of Data and Performance Management, who will take you through a deeper examination of what the FP 2020 core indicators are telling us about family planning across the 69 FP 2020 focus countries as of July 2017. Thank you. Jason, over to you.
Thanks, Beth. The launch of FP 2020's annual progress report is the culmination of an annual process of engagement on family planning data that represents the efforts of many, many partners. It includes the efforts of data collection agencies such as the Demographic Health Survey, the UN Population Division, UNICEF and their Mix Survey, PMA 2020, and providers themselves who fill out registers and track the services that they provide. It includes Track 20 and the country monitoring and evaluation officers who work with countries to produce estimates. It includes FP 2020 focal points and country stakeholders who regularly review data and progress. It includes global partners such as the Kaiser Family Foundation, the Netherlands Interdisciplinary Demographic Institute, Countdown 2030 Europe, and others who track family planning financing. It includes the FP 2020 Performance Monitoring and Evidence Working Group, or PME Working Group, who work to review FP 2020 reporting and align family planning measures. And it includes the donors, including the core conveners of FP 2020, who support many of these efforts. I believe we can say with confidence that we are in a better place today with regards to measuring progress toward our FP 2020 goals and ultimately the goal of universal access than we were at the outset of this partnership in 2012. Thus, it's a privilege to work with all of these partners and have the opportunity to represent their work and present the data from the 2017 progress report to you today. As a reminder, FP 2020, through a consultative process with measurement experts, has established a set of quantitative metrics we call the 18 core indicators to help countries and the global community track progress annually across diverse dimensions of a family planning program. For our first 8 core indicators, shown in blue here, FP 2020 produces annual estimates of progress using statistical methods developed by Track 20 and partners that take advantage of all available nationally representative surveys and increasingly also incorporate country service statistics. The remaining indicators, shown here in green, come from the most recent data source available in each country. Full definitions for the indicators and information on the methodologies and models can be found in the progress report as well as on both FP 2020's Measurement Hub and the Track 20 website. I won't spend more time on methods and definitions today, though I'm happy to answer specific questions during the Q&A portion of the webinar. This graphic shows the process each year for developing annual estimates for the FP 2020 progress report. Estimates for the core indicators are produced through a network of country-based M&E officers housed in government institutions and trained by the Track 20 project at Avenir Health. Much of this work happens in the first and second quarters of the year as countries aim to hold a data consensus workshop by June 30th to review and discuss their progress. Our FP 2020 global partners spend quarters 3 and 4 reviewing and analyzing data and drafting and producing the progress report. The regularity of this process over the last several years has opened new spaces at many levels for analyzing, examining, discussing and using data for decision making. Okay, so let's start to look more closely at the progress data. What you see here is a graphic that shows the total number of contraceptive users by year across all of the 69 FP2020 countries. You can see on the left side of the graphic that in 2012 there were approximately 270 million users of modern methods of contraception. We should also show that in a light blue box to show that 270 million base over time. In each subsequent year, that number has grown, and now in 2017 there are 309 million women and girls using modern methods of contraception. Comparing 2017 to 2012, you can see in dark blue that there are now 38.8 million additional users of modern methods of contraception. You can also see the orange line that represents our trajectory since 2012 as compared to the historic rate of growth in gray. We've made considerable progress toward reaching more women and girls, though as you can see from this graphic, our progress is not yet rapid enough to put us on a path to 120 million additional users by 2020. Progress is variable across regions and across countries. This graph shows the average annual percentage point increase in the modern contraceptive prevalence rate, or MCPR, since 2012. You can see that growth in modern contraceptive use varies greatly across regions. Asia includes 4 of the 5 most populous FP2020 countries: India, Indonesia, Pakistan, and Bangladesh. Because of their size, progress in these countries has a large influence on progress toward the FP2020 goal of 120 million additional users. In 2017, 38% of all women of reproductive age in Asia were using a modern method. This is our highest level of MCPR across the regions. The modern contraceptive prevalence rate across regions of Asia, however, is growing by just between 0.2 to 0.4 percentage points per year, shown in the upper parts of this graph. In contrast, the pace of MCPR growth in Africa over the last several years has been much faster. Since 2012, MCPR among all women has grown from 19.5% to 23.4% in the region, with the fastest growth occurring in Eastern and Southern Africa, the bar shown at the bottom of the graph, at 1.2 percentage points increase per year, followed by Western Africa at 0.8 percentage points increase per year. At a country level, the 41 countries that have made FP2020 commitments are tracking progress towards the goals that they've set for themselves. This graphic shows countries ordered from left to right in relation to their progress toward achieving their FP2020 goal for modern contraceptive prevalence rate. The blue bars represent their goals in 2020 for MCPR, and the green bars show their projected modern contraceptive prevalence rate for all women based on current progress, or where they would be in 2020 based on the current trend. This box that I've just added to the graphic shows that there are now 12 countries that are on track or within close reach of achieving their FP2020 goals. And the number of countries who are on track has risen each year. Countries are increasingly using data to assess and adjust their family planning programs by identifying areas where they can improve current programming, by identifying underserved populations and geographies, and by identifying opportunities for investment. And we'll look at a few of the tools that countries are using now. The S-curve pattern of MCPR growth described in depth in last year's report, and again this year, remains an important tool that helps countries assess their current MCPR levels, assess the expectations and opportunities for growth both at national and subnational levels. And this S-curve is based on historical patterns of MCPR growth, and we generally group countries into 3 categories. You can see on the right-hand side of the S, high prevalence countries, where growth is leveling off and countries are often exploring opportunities to expand method choice, reduce inequity by reaching the underserved or different geographies, and ensure sustainability through domestic financing options. Countries in the middle group, or countries with moderate prevalence, where there's an opportunity for rapid MCPR growth, are focusing their FP2020 efforts on opportunities for acceleration, including service delivery high-impact practices, supply chain improvements, social behavior change interventions that influence barriers to contraceptive use. And low prevalence countries, shown on the left side of the S, are still experiencing slow growth. And in addition to establishing the basic components of a family planning program, need to assess the right balance of investments between expanding family planning services and undertaking social and behavior change activities that affect the social and cultural norms affecting motivation to use contraception or not to use. Building on this last concept of the balance of investments, a concept that we feature this year in the progress report that Track 20 has developed to help countries assess that right balance of investments is called the Maximum Contraceptive Prevalence Demand Curve, shown here. The demand curve, the blue line, represents the likely maximum MCPR that can be reached given fertility intentions, or the ideal number of children, and related norms and constructs that influence contraceptive use. It's based on historic relationships between MCPR and the mean ideal number of children, and the gap between where a country sits vertically in relation to the curve is called the potential use gap. Let's take a quick look at a few countries to better understand this concept. In countries shown in red, such as Tanzania, which you can see just about in the middle of the graphic here and very close to the blue line, the gap to the line is small, and historically few countries have seen higher levels of MCPR with that same ideal number of children. Thus, investments in social behavior change are likely needed as there may be limited potential for growth in MCPR through investments in expanded service delivery alone. In contrast, let's look at Benin. You can find Benin near the bottom of the axis here, the lower axis, and a little bit to the left. And Benin is marked in green, where the potential use gap, or that gap to the curve, is large, and much higher levels of MCPR have historically been seen at that same ideal number of children. Countries in green are more likely to see substantial increases in MCPR from investments that expand family planning service delivery. This conceptual tool, in tandem with the S-curve, are helpful in stimulating dialogue about investments and expectations and encouraging additional analysis that help countries assess their balance of investments. I also want to point out that these S-curves and the demand curves that I showed on the last slide are available at national and subnational levels. This S-curve here is for Kenya shows the great variation across counties in MCPR levels. You can see that Kenya has many counties with high prevalence on the right-hand side, as well as some, principally in the north of the country, with extremely low prevalence. So a differentiated strategy is needed across these geographies. You can find subnational S-curves and subnational maximum contraceptive prevalence demand curves for most FP2020 focused countries through the data portals on the FP2020 and Track 20's country pages. Let's turn to some different measures. Core indicator 4, or demand satisfied for modern contraception, is also an indicator for the SDGs. This figure shows regions ordered from left to right according to the highest to lowest levels of demand satisfied, which are shown in the circles above each bar. I know that demand satisfied is a complicated indicator, and we hope to help the family planning community better understand over the coming year this indicator. Demand satisfied with a modern contraceptive method is constructed based on both MCPR and unmet need for modern methods, which together comprise the total demand for modern methods. So you can see that total demand in the height of the vertical bars. You can see that it's the combination of the MCPR in blue and unmet need marked with hashes. The proportion of these women with demand who are using a modern method is termed demand satisfied. So you can see that it's the proportion of the total demand, or that vertical bar that's filled by the dark blue, that is demand satisfied. You can see that a few regions have already surpassed the proposed 75% demand satisfied SDG benchmark. And this progress report shows the variation at the country level. I encourage you to explore it. And it's important when looking at the data to understand the dynamics of both unmet need and contraceptive prevalence that are at play in this indicator. For indicator 9, or modern contraceptive method mix, measures the distribution of modern contraceptive users by the method they use. This graphic shows the most commonly used method in each country, with the different colors representing different methods. You can see here, for example, orange represents injectables, the green represents IUD, the blue represents sterilization, and you can see many other methods are represented as dominant methods across the countries. The fill of each box shows the percentage of the method mix represented by that dominant method. I think it's important from the outset to contrast method mix, which measures what people are using, versus method choice, which is more broadly about what methods women and their partners can choose from. While there's no right method mix or ideal method, there's broad consensus that providing access to a wide choice of methods is essential to providing quality of care and ensuring full choice in family planning from a rights-based framework. Injectable contraceptives remain the most common method across the largest number of FP2020 countries, as you can see here from the orange boxes. And trends suggest that increases in contraceptive prevalence rates in many countries are being driven by growth in injectable contraceptives and implants. While expanded method choice is difficult for us to measure, we do see a wide range of methods in use within countries. And there are now 27 countries in which 5 or more methods are in use, something that we'll continue to track over time. We're featuring some new graphics this year on core indicator 14, or the Method Information Index, which I think is particularly important because it serves as a measure for quality of counseling and is a summary measure constructed from 3 questions asked of current contraceptive users about the occasion when they obtained their current method. These questions are shown in the upper left and include: were you informed about other methods? Were you informed about side effects? And were you told what to do if you experience side effects? The Method Information Index total, shown here in the orange bar, is the percentage of respondents answering yes to all 3 questions. So in the report, you will find the Method Information Index total. You'll also find the Method Information Index value by method, which gives you a sense of different quality of counseling across methods. And you'll see, of course, the percentage of women who positively answered each question, which here is shown by the 3 different dots in each country graphic. You can see by looking at the orange bars that the Method Information Index values span a very wide range from 13% of contraceptive users in Pakistan to 71% of contraceptive users in Zambia who responded yes to all 3 questions. Looking at the individual components, I think by looking here at the countries, you can see a general trend or downward trend on those lines. So if we look at those individual components, we can see a greater percentage of women report receiving information on our other methods than report being informed about side effects or how to handle them. Long-term trends available from the DHS show that most countries with multiple surveys indicate an improvement over time in counseling. But for this progress report, I've compared the two most recent surveys, and I think this reveals that few countries have made recent progress in the Method Information Index measures of providing counseling and information to women adopting a contraceptive method. These findings show that there is ample room for improvement in counseling across the 69 FP2020 focus countries. I know I've been stretching your minds a bit here on the graphics and the complicated data that they represent, and I'll try just one more with you, and that is on core indicator 18, which we added this year and measures 12-month rates of contraceptive discontinuation and contraceptive method switching for each method. By measuring the rates at which women stop using methods, as well as the rates at which they switch from one method to another, core indicator 18 provides a fuller picture of the dynamics, or what we call churn, of contraceptive use as women begin using a method, stop for a variety of reasons, start using a method again, or switch to a preferred or more effective method. It's important when you think back to our additional users graphic and you think of the base of users and the additional users, it's important to remember that these aren't the same people over time, that there's a churn of users constantly going on, and contraceptive discontinuation rates help us to measure that churn. The graphic here shows discontinuation rates by method for countries, with each method represented in a different color and each country represented with a circle. We grouped the reasons for ease of interpretation into two categories: discontinuation while the woman is in need of contraception, and discontinuation because a woman is not in need. You can see in the left graphic, which shows discontinuation while in need, that the cloud of country circles for short-term methods spans a wide range and is generally higher than for long-acting methods. In order to understand and effectively address discontinuation, more in-depth analysis is needed on a country and method-specific basis to determine the root causes of this churn in use. And I encourage you to explore the contraceptive discontinuation and switching data as just a starting point for analysis and dialogue. Finally, I'd like to highlight two areas where FP2020 and partners are continuing to work to overcome data gaps that limit our tracking of FP2020 priorities. First, I'd like to call attention to our recent work with the PME Working Group and partners to draw attention to data gaps on adolescent contraceptive use. In tandem with the 2017 Family Planning Summit, we published a commentary on adolescent data gaps on contraception and recommendations on these gaps. Shown here, it's available on our website through the adolescent microsite that Beth discussed earlier. In the coming year, we'll be continuing work with partners to follow up on the recommended actions. We do report on adolescent birth rates by country in the progress report, but the commentary points out that this indicator may be insufficient alone in capturing contraceptive use trends among adolescents. Second, I'd like to highlight our work to improve tracking of domestic expenditures, which continues. While we made progress this year at aligning partners' efforts, we are again not reporting on domestic expenditures on family planning by country in the progress report. A companion piece that explains these efforts and the challenges to tracking expenditures or domestic expenditures on family planning, as well as our donors' expenditures and out-of-pocket expenditures, is newly available on the Track 20 website, should be launched this week. With that, I'd like to turn it back to Beth.
Thank you, Jason. As always, we learn a lot whenever you speak in brief, and I do challenge everyone to spend some time with those graphics, because there's a wealth of information within each of them, and we look forward to learning from all of you as you share back with us how they're most useful and what more we can do to expand the measurement agenda. So with that, I'd like to introduce our next speaker, Adam Wexler, who is Associate Director of Global Health and HIV Policy at the Kaiser Family Foundation. And Adam is going to be briefing on donor government assistance for family planning. So over to you, Adam.
Thank you, Beth, and thank you everyone here at FP2020 for giving us the opportunity to speak and present our latest findings. First, I'd like to give an overview of how Kaiser Family Foundation got involved in this analysis, and also an overview of the methodology we use. We first started collecting data on donor government funding for family planning following the original London Summit in 2012. At that time, we adapted the methodology we've used for a decade and a half to monitor donor government spending on HIV in conjunction with UNAIDS. Current report presents 2016 funding data, which is the most recent year available. We now have data available for the period between 2012 and 2016. So what are we looking at when we collect this data? We include disbursement data from all members of the OECD DAC. And we do direct data collection from 10 donors: Australia, Canada, Denmark, France, Germany, the Netherlands, Norway, Sweden, the UK, and the US. Combined, these donors account for approximately 98% of total donor government funding for family planning. Data for all other OECD DAC members are collected from the OECD CRS database. What we're looking at specifically, and when we assess bilateral funding data, is any earmarked or FP designated amount, as well as FP specific contributions to multilateral organizations. For instance, a donor contribution to UNFPA supplies. We also attempt, where possible, to collect FP funding data provided under other development assistance activities. For instance, an education program that might have a portion of the funding directed to FP. We would include that FP portion. For the 10 donors that we conduct direct data collection, the data is validated by all of those donors for this analysis. We also look at donor contributions to UNFPA's core resources, something we'll get into later in the presentation. So what did we find this year? Donor governments dispersed approximately $1.19 billion for family planning activities in 2016. This is a decrease of over $150 million, or 12% below the 2015 levels. This year marked the second year of declines after initial increases following the London Summit in 2012. While the declines were largely due to the appreciation of the US dollar in 2015 and an apparent delay in the timing of US disbursements, something I'll get into later, we did see that several donors did actually decrease funding in 2016. Overall, however, in 2016, 5 donors, Australia, Denmark, Germany, the Netherlands, and Sweden, increased funding. 1 donor, Canada, remained flat. And 4 donors, France, Norway, the UK, and the US, declined. This figure here shows funding over time from 2012 to 2016 in both current and constant dollars. The blue bars are current dollars, so as you can see here, funding after the London Summit increased in 2013 and 14, but then declined in 15 and 16. The line shows constant dollars, so as you can see in 2015, when you take into account the appreciation of the US dollar, funding was actually flat compared to 2014 levels. But what we see, even adjusting for inflation and currency exchange rate fluctuations, funding in 2016 declined in constant dollars. So as I mentioned before, a lot of the decline in 2016 was due to timing of the US disbursements. What this figure attempts to show is kind of one of the unique situations with the US. Each year, Congress appropriates a level of funding for family planning, but that funding may be dispersed over a multi-year period. So for instance, in 2012, you see that over $600 million was appropriated for family planning, but in that year, $485 million was dispersed. In subsequent years, disbursements were greater than the appropriated level, but then in this year, in 2016, as you can see, the disbursements were below the appropriated level. This is a normal fluctuation that occurs over time, and we anticipate that over time it will level off to what has been essentially a flat funding from Congress for family planning. Even after the decline in 2016, the US was the largest bilateral donor, accounting for 45% of total bilateral funding. The UK was the second largest donor, accounting for 17%, followed by the Netherlands at 15%, Sweden at 8%, and Canada at 4%. The US and UK have accounted for approximately 2/3 of funding over the entire period, and trends are largely continue to be driven by these 2 donors. This figure here shows the disbursements in 2016 over the whole period, shows the trend. And as you can see here, the U.S. and the U.K. account for the majority of funding. Right. As I mentioned earlier, we also look at UNFPA's contributions from donors to UNFPA's core and non-core resources. Contributions to non-core resources are included under bilateral totals if specified by the donor for FP activities. Again, donor contribution to UNFPA supplies would be included. Contributions to UNFPA's core resources are meant to be used for both programmatic activities, for instance, FP, but also HIV and other activities, and general operational support. In 2016, donors contributed approximately $315 million to UNFPA's core resources, a decline of almost $45 million or 13% below the 2015 level. Among the donors profiled, Sweden provided the largest core contribution to UNFPA of $59 million, followed by Norway at almost $47 million, the Netherlands at $39 million, and the U.S. at almost $31 million. UNFPA estimates that in 2016 it provided $319 million, or 40% of its total resources, both core and non-core, was spent on family planning. A report detailing all of the information I've highlighted today is being released actually about an hour ago. So please go to our website and download the report. We'll begin data collection for the next report in early 2018, looking at 2017 family planning disbursements. With that, I want to say thank you again to FP 2020 and hand it back to Beth.
Thank you, Adam. We all look forward to seeing the report today. And again, I encourage everyone to go to Kaiser Family Foundation's website and take a deep look. So with that, we'll now turn to the Q&A portion of today's webinar. And I encourage everyone to submit your questions online. Or again, if you're not part of the webinar and you're on a phone line, you can submit them directly to colleagues here by using info@familyplanning2020.org. So with that, I'll start with our first question. Joan Cunningham asked if the U.S. is a participating country, and if not, please explain. I ask because of the increasing difficulties in getting family planning to poor women everywhere. Thanks for your question, Joan, and I think that Adam explained the financing situation with the U.S. government. USAID, U.S. government, has been a core partner of family planning since the original Family Planning Summit in 2012, and they remain, again, the largest funder and technical partner in the field. But because of the funding process with the U.S. government, USAID was not able to make a political commitment to FP 2020 with regard to financing year over year, because every year the appropriation depends on the decision made by Congress. But they, again, remain committed to family planning as an issue at this time, and so they participate at all levels of family planning as focal points in every country where they're working on reproductive health, and as members of the reference group, and again as our core group here at the Secretariat. So we very much hope that that relationship will continue in the coming years. We also had a question from a colleague who wondered if this, I think it was Seder Alam, who asked if this briefing was U.S. specific. So, Sardar, I think what you're hearing this year is a deeper dive on the U.S. situation, both because of the importance of U.S. funding, bilateral funding to the sector as being almost 50%, and because of the uncertainty and some of the cross signals that have been sent by the Trump administration with regard to the continued U.S. support for family planning. So given the weight of that, I think you're just hearing a little bit more about that this year than perhaps in other years. But again, the partnership is a global partnership with many donors, many technical partners, and country governments and their own domestic financing remain the core of what we need for to grow family planning in countries around the world. We also had a question that I'm going to turn to Jason, which is how can we continue to develop our ability to assess how much funding is going to support family planning? So Jason?
Thanks, Beth. not exactly an easy question, and something that we continue to work hard on, as I mentioned. Our colleagues, both at Kaiser Family Foundation, along with many other partners, some of whom I mentioned, NEDI, Netherlands Interdisciplinary Demographic Institute, as well as Countdown 2030, DSW, the German Population Foundation, as well as Track 20, particularly John Stover, have been working together in what we call the International Family Planning Expenditures Tracking Advisory Group to look at the different ways that that partners are tracking these expenditures. So there are multiple partners who track donor expenditures, multiple partners who are trying to measure what consumers are spending, as well as multiple partners who are trying to track domestic expenditures or what countries are spending themselves. It's not easy to collect that last piece of data from countries, and we continue to struggle to come up with what we believe are quality data that are comparable across countries. In the progress report, we do report on total expenditures for family planning. We show a graphic that indicates that about 50% of total expenditures in the FP2020 countries come from donors, and then the other 50% come from consumers themselves or from domestic country governments. So we have a 69 country estimate, but when you start breaking that down into each country's data, things get a little messier. So a key component that we're trying to achieve this year is to have countries validate their data in these country data consensus workshops. So they're examined thoroughly, they're reviewed by the family planning program and stakeholders before they are put into the progress report. That's what we aspire for.
Thank you, Jason. Our next question is from Grace Shea-Phillips, and she asks, how are FP2020 organizations looking at public-private partnerships or any collaboration with private companies for funding, service delivery, etc.? Okay, so thank you for your question, Grace. We actually saw a great uptick in these kinds of partnerships for the summit, where 9 partners came together to share their goals for reaching, or these were private sector partners, for increasing access to contraception. I'll give a good example of that. They tended to be corporations who were, many of them were international corporations who were working in specific countries. For example, Twinings Tea made a commitment to reach 40,000 women with contraceptive services who are working with their tea plantations in Kenya. So that was a great example of an organization who's looking to increase the provision of health care for their workforce overall, and then within that, recognizing the importance of and the opportunity for rights-based contraception. Again, when we work with partners on developing these kinds of public-private partnerships, we really emphasize the need for a rights-based approach so that contraceptives are available to increase health and for women to choose to use them, not as a condition of employment, but rather as a holistic approach for health care overall. So as the opportunities for these kinds of partnerships were opening up, we are talking more internally about how we can be better organized to reach these corporations. It does remain a little bit more challenging to have multinationals or larger corporations stepping out in support of reproductive health overall for the entire sexual and reproductive health continuum of care. We continue to try to make this space one where companies understand that supporting women is a great economic strategy for their investments, but also critical for corporate social responsibility. So again, partners continue to work on that, and we're hoping that this will present a growth opportunity in the years ahead. Our next question, I'm going to turn to Jason, and this is from Judith Helsner. And Judith asks, if people are planning program efforts in specific countries, what is the best way to take advantage of the indicators? For example, Niger and Benin are in different places on the S-curve, and maximum contraceptive prevalence demand curve. How do you recommend using that information for program planning? Jason?
Great question. I'm glad you were paying attention, Judith. You're right, Niger and Benin are in very different places on that curve. And Niger has actually been one of the success stories of the, I think, of the OP, seen some growth in contraceptive prevalence rates in the last several years. But as you note, as they approach that demand curve, or that gap gets small, they are actually using this information. These are focal points and family planning stakeholders who are assessing what they have been investing in and whether or not they can expect continued growth based on those investments. And their investments have largely been focused on a service delivery side. Those are critically important, but they, at this point, with that small potential use gap, they're unlikely to see further growth at the current levels of ideal family size. So there's historically very few countries that have seen higher MCPR at that ideal family size level. So the conversations are about that balance of investments in social behavior change communications, which they have not invested heavily in to date. So the focal points there are having these conversations, talking about the investments, identifying partners who can help them with those high-impact practices on that front. Benin is, as you noted, in a different place, and Benin can likely see further gains through investment in service delivery, in supply chain, because levels of MCPR much higher levels of MCPR have been seen historically at that ideal family size. So I hope that helps. Beth, there were a couple other data questions. You want me to read those, or do you
no, go
want
for
to
it.
read them? Okay, I'm going to try to answer these relatively quickly. One was, what are the SDG targets for those countries which have already achieved the global target of 75%? That's a great question, and in fact, I think there's a little bit of confusion, as I noted, around the demand satisfied indicator. There is actually not an official global target of 75%. The indicator itself, there's a great paper by Ellen Starbird and colleagues who look at the levels of demand satisfied and propose 75% as a benchmark that countries should aspire to. But certainly for those countries that have already surpassed 75%, there are historically higher levels up into the 80s, and I think those countries should continue to strive to meet demand. And then for those countries who are well beneath the 75% target, there are, of course, investments they need to make both in increasing MCPR, decreasing unmet need, that will allow them to move forward towards those 2030 targets. At a country level, we know that around 11 to 15 countries are already within reach of that 75% satisfied target. Lots of work still to do, even if you surpass that. And then there was a great question about whether or not we had any insight on why discontinuation of short-acting methods are higher in many countries when women are in need. And a great question, again, shows that you were paying great attention to this difficult to understand indicator. What we see in terms of the discontinuation rates for short-acting methods is high levels of discontinuation, particularly for reasons of side effects. So one thing that we certainly need to look at is what I mentioned on the quality of care on counseling, method availability, and method choice. I think it's pretty natural that we would expect to see higher discontinuation rates among those short-acting methods. Those are methods that are thinking about pills and injectables, that it's easy to either lapse, it's easy to stop. So I think functionally we expect higher levels, but I think that what we get a sense of is that also quality of counseling and care needs to increase around these methods, so that when people have side effects, they either have other methods available to them or know what other versions of that product might have less side effects.
Right. Thank you, Jason. We have another data question for you, but I'll read one from Saswati Das first, because he's asked, is there any guidance or recommendation on how to expedite FP2020 progress or any country-specific decisions to expedite that progress? So I'll get started with that and then maybe turn that over to you in case you have anything to add. So Saswati, what we've seen is that the critical element, first of all, the context for every country is different, depending on what the challenges are. The S-curve showed that, and then the subnational S-curve shows that even within countries, there are different issues that need to be addressed in order to expand access. But the critical element that we've seen where countries are advancing progress is country leadership and ownership of their program. So where countries are investing in family planning programs as an important element of primary health care and delivery of all health care for women, that's where we're seeing advances, because it's that political commitment from the highest levels and through Parliament that can start to open up that space for dealing with some of the cultural barriers that women face in accessing family planning. The elements that are also necessarily are ensuring quality of care, so that when women access services, they're having their needs met, depending on where they are in their reproductive lives, because what women need over the years transitions. So a wide range, a wide method mix of quality assured contraceptives that are available again through a caring and high quality healthcare system are the foundation of growing this. But again, that remains aspirational in some context. So what we try to ensure is that while we're working on the technical aspects of service delivery at the country level, we're also creating an environment wherein the needs of women and girls are seen as critical to development. And so the partnership is trying to advance this at all fronts. And we need all partners to work with us or to continue to lead, as many have over the decades, in creating that environment. Jason, the question I'm going to turn to you is from Jarara Sadikan. My apologies for butchering your name. And they've asked, do we have a breakdown of new users among adolescent girls?
Great question, tough question. First, I just want to distinguish that we are using the word additional users, in which we differentiate and are careful with respect to new users. In fact, earlier this year, the PME working group issued a statement on the difference between additional users and new users and issued some guidance on why those two terms are not the same thing. I encourage you to go to the FP2020 Measurement Hub to read up further on additional users versus new users. So that said, the question of whether or not we're able to report on additional users who are adolescents, we are not able to do that. Our additional users data are essentially constructed from knowing our MCPR levels, and we know them in 2012 and we know them in for each of the years to 2017, using a statistical model. And that statistical model allows us to make estimates at a national level with all available data, but not to break down that projection or that estimate into subcategories or disaggregate it by wealth quintile or by age group. So we're essentially estimating the MCPR based on a complicated statistical model, and as you break that out into subgroups, the data get messier and messier as the sample size for those groups gets smaller and smaller. And our sample sizes for adolescents in most of these countries are small, and that hampers our ability to estimate at that level. It's something that the UN POP Division and Track 20 and other partners in academia are working on, continued improvements to that model that in the future may give us a better idea of smaller groups and their progress over time. That said, this is something that we are looking at, as I mentioned, moving forward this year with some work on adolescent data gaps, and we'll continue to strive to be able to provide more information on adolescent contraceptive use trends. Thanks. And then I think we have a few financing questions that we want to turn to Adam. And so 2 funding questions, Adam. The first is, what was the reason for the funding decline between 2014 and 2016?
Great, thank you, Jason. So there were a couple of reasons. First, let's look at 2015. In 2015, we saw that there was an appreciation of the US dollar. So if a donor gave 10 million euros in 2014 and gave 10 million euros again in 2015, that was worth less in US dollars in 2015. And so between 2014 and 2015, we saw a significant decline, but when we take into account the appreciation of the US dollar and adjust all donor government contributions to remove that appreciation, we see that funding was actually flat in constant dollars. So it was really, 2015 was due to the global appreciation of the US dollar. In 2016, we saw, similarly, the pound depreciated against the dollar, so the dollar was worth more than the pound than in previous years. So that drove a portion of the decrease. But the larger portion of the decrease was due to timing of U.S. disbursements. As I mentioned before, the U.S. situation is somewhat unique. There is funding appropriated by Congress on a yearly basis, but that funding may be dispersed over multiple years. So you could see an appropriation in 2012 that won't fully be expended for a multi-year period, even still going on now. And what we've seen over time is that there have been years where disbursements have been higher than that annual appropriation and years when it's been lower. This is one of those years where we saw that the disbursements were below the actual appropriation. And we expect that over time, funding will level off because the annual appropriation from the U.S. Congress has been essentially flat for the last 5 years. So it's entirely possible that next year the U.S. could go up. It may still be the same, and the increase or the difference might be made up in future years. It's hard to know, but we'll see and continue to track in the years to come.
So I think, Adam, a good follow-up to that is a question we also have coming in on the Q&A box, which asks, be great to hear if there are any changes in funding from the U.S. that are anticipated in 2018. And I'll first turn to Adam, and then Beth, if you want to add anything further, I'll go ahead and turn back to you.
Thank you, Jason. And as Beth mentioned in response to a question earlier in the presentations, we're focusing a lot on the U.S. because the U.S. accounts for such a large portion of the donor government funding. And as some of you may be aware, the current administration has proposed some significant changes to what the U.S. would do. Starting with the President's request for 2018. In his request, he proposed to eliminate all funding for family planning. However, Congress has proposed 2 bills, one from the House and one from the Senate, both of which did include funding for FP. So Congress is the ultimate decider on the funding levels, and they're currently still negotiating what those levels will be. We are seeing that it likely won't be resolved in the next couple of weeks, but when it is resolved, we anticipate there will be some funding for FP. The question is how much. The House bill proposed a level of $460 million roughly, and the Senate proposed prior year levels. So ultimately, it will be determined. They have to negotiate and come to a level between them, but it won't be the level initially proposed by the administration, which is 0. Another point to highlight is the fact that the administration has invoked what is called the Kemp-Casten Amendment, which I will defer to Beth to highlight a little bit more on, but ultimately what that says is that the U.S. will no longer be providing funding to UNFPA. Where that proposed funding Congress has included in the past, where that might go remains to be seen.
Elsie Nolette, who asks, one of FP 2020's core data points monitors unsafe abortion. Does FP 2020 make the distinction between safe and unsafe abortion in its data collection? Do you have data reflecting women wanting to opt for safe abortion options as part of a rights-based family planning service provision. Jason, I'm going to turn that question to you.
Thanks. So let me clarify a few things on our impact data, which are core indicators 5, 6, 7, and 8, of which one of them is unsafe abortions averted. So here we are not actively collecting data on abortion at a country level. And so other partners, particularly the Guttmacher Institute, are continuing to advance the methods on estimating safe and unsafe abortion rates at country and regional levels. I encourage you to go to the Guttmacher Institute's website. They published a new report in September of 2017 called Global, Regional, and Sub-Regional Classification of Abortions by Safety, 2000 to 2014. So that will really, I think, give you what you're looking for in terms of the distinction between safe and unsafe abortions at and the data collection for that. What we are doing is essentially estimating the impact of contraceptive use on the number of unsafe abortions that would be averted. And this is done essentially by looking at comparing the number of women who are using different methods of contraception between years and the unintended pregnancies that are averted by the change in contraceptive use, and then looking at the total impact of that. So we can estimate the number of unintended pregnancies due to contraceptive use in a country, the number of unsafe abortions averted, as well as the number of maternal deaths averted. So each of those is estimated using the Impact 2 model, originally developed by Marie Stopes International. You can find great resources on the Track 20 website and on the FP2020 Measurement Hub about the methodologies, and that will give you more information on that. Just want to take the opportunity while we're on data to also mention that all of the PowerPoint graphics that I showed today, as well as all of the PowerPoint graphics in the, or all of the graphics that are in the print report, PDF report, and digital report are available on the FP2020 website, the progress report website, which you've already seen links for. And I encourage you to explore those, to ask questions of FP2020 and Track 20 as you move forward about that data. There's nothing better than hearing from partners and hearing questions, and for all of you asking us for more resources. That gives us a sense that you're using that data for dialogue and for decision making. So please go to those sites. Thanks.
Thank you, Jason. So as Jason mentioned, there is a richness to the data, lots more to explore, many partners who are working on all of this, and a lot to learn. We look forward to hearing from you about how we can shape this partnership to be as effective as possible and to meet your needs as well. So please do consider us as thought partners and engage with us on how we can shape the information that we're sharing and the work that we do to better meet the needs of all of you working in the field. So with that, those are the last questions that we've had. This has been a great Q&A. We really appreciate the back and forth. I think the system has really worked well for us today. So thank you all for your engagement and your partnership. It's very exciting for us to launch the FP2020 Progress Report today. And again, we look forward to your feedback about the report and about what more we can do to make the sector more effective for all of you. You're the ones working in the field. You're out there every day with women and girls delivering these services. So we thank you for your partnership. We're here to support all that you do in any way that we can. So again, thank you and have a great day. Bye-bye.